morning to one and all. Thanks for joining on time. On behalf of MQR Pharmaceuticals, I am Edward Pereira, and it's my pleasure to welcome you all for this webinar series organized under the aegis of Mumbai Hematology Group and under the leadership of Dr. M.B. Agarwal, sir. At MQR, it's a commitment to collaborate with clinicians and provide platforms for scientific discussions on latest updates in the patient care. We are indeed grateful to Dr. Agarwal, sir, for giving this opportunity to be the part of this scientific fest. And for leading the sessions today, I am honored to invite Dr. Dipanjan Dipanjan Haldar from Mumbai. A brief about Dr. Dipanjan. He is a practicing hematologist and hemato-oncologist and BMT physician at Wockhardt Hospital, Mumbai. Sir has a rich experience of more than 12 years in field of hemato-oncology and is a gold medalist from West Bengal University of Health Sciences. So without any further delay, I would like to call upon Dr. Dipanjan, and I would like to hand over the session to him. Over to you, sir.
Thank you, Mr. Edward. I'd request Kalpesh to please start the screen sharing.
Sir, you can see my screen, right?
Not yet. Yeah. Good morning, one and all. And on this Sunday morning, we have Dr. Ashutosh Vechlekar from London, UK as our guest speaker. Next. So he will be talking to us about AL amyloidosis, what is new. Next. This lecture this Sunday morning is brought to you by Mumbai Hematology Group. Next. And we have MQR supporting us. And for the event management, we have Perfect Square. Next. At the outset, I would like to thank Mr. Keyur Soni and team MQR, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest, Dr. Manju Sengar Madam, who has agreed to be the chief guest for today's session, our guest speaker, Dr. Ashutosh Vechlekar from London, UK, who has agreed to give us the talk this morning, all our discussants who are themselves eminent hematologists for sparing their Sunday morning, and all participants for taking part in this lecture. You can visit our website, www.mhgindia.com, next, to see our future plans and activities. In the next Saturday, that is on 27th of August evening, 7 p.m., we have a lecture on CNS relapse in diffuse large B-cell lymphoma, risk stratification, prophylaxis and treatment by Professor Dr. El Ghali. He is consultant hematologist at Denmark. Next. And on the coming Sunday morning, that is on 20th August, 11:30 a.m., we have a lecture on flow cytometry and its interpretation in chronic lymphoproliferative disorders by Brigadier Dr. Tathagata Chatterjee. Next. On Saturday and Sunday, that we have midterm conference that is on 3rd and 4th September, 8 a.m. onwards. This will be a physical conference after about 2.5 years. And this will be hosted in SP Jain Auditorium, 4th floor, new wing of the Bombay Hospital. All of you who have not registered can register, and all of you are welcome to attend this awaited conference of Mumbai Hematology Group. After about a gap of 2.5 years, we'll be having a physical conference. Next. September is also the Lymphoma Awareness Month, and we have arranged a talk on lymphomas daily from Sunday to Thursday, that is 11th to 15th of September in the evening time. So if you can spare your evening, this is all you know about, need to know about lymphomas. This will be a daily talk, evening for discussion and next. Kalpesh, can you go to the next slide? So to introduce the guest speaker, Dr. Ashutosh Vechlekar. Next. So he is Professor of Medicine and Hematology and Director of Jacobi Center, University College of London, Department of Hematology, University College London Hospitals, Department of Hematology. Next. Sir had his initial medical training at medical in UK. He did clinical research fellowship in myeloma and related disorders in Toronto, Canada. In 2004, he joined the UK National Amyloidosis Center as a senior research fellow, funded by a grant from Leukemia Research Fund. Next. His scientific interests are focused on characterization and treatment of systemic amyloidosis, multiple myeloma, and Waldenström macroglobulinemia, with focus on the biology of plasma cells and to study agents in these disorders. He has the UK Amyloidosis Network and is a member of the British for developing guidelines, treatment of myeloma and amyloidosis. He has published extensively in these areas. He is also a member of the International Consensus Panel. He has set up a website, www.mutations.com, which is a continuously updated free web source detailing all known mutations in hereditary amyloidosis. Next. We have a galaxy of discussions for today's morning's lecture. We have Dr. A.K. Tripathi from Lucknow, Dr. Chitra Madiwale, Next. Dr. Amita Chakraborty. Next. Dr. Ashish Dixit is consultant. Dr. Chandrakala, madam, is in Mumbai. Dr. Dr. Gaurav Dixit is Dr. Govind next. Dr. K.S. Natraj, he is head of department, senior consultant hematologist, hemato-oncologist, and transplant physician at Sri Shankar Cancer Hospital and Research Center, Sankarapuram, Bangalore. Next. Dr. Mona Vijayaran, she is consultant clinical hematology at Sahara Hospital, Lucknow. Dr. Nakul Tikare, he is senior resident DM clinical hematology at AIIMS, Bhubaneswar. Dr. P.P. Abdul Rashid, he is medical oncology consultant, medical oncologist at KIMS Cancer Center, Trivandrum. Dr. Pravash Misra, sir, is director hematology and BMT Max Hospitals, Patparganj and at New Delhi. Colonel Dr. Rajan Kapoor, sir, is professor, Department of Medicine, consultant hematologist, Command Hospital, Eastern Command, Kolkata. Dr. Rajiv De, sir, is professor, Department of Hematology at NRS Medical College. He is also visiting consultant hematologist, hemato-oncologist, and BMT physician at Narayana Super Specialty Hospital, Kolkata. Dr. Ramesh is senior resident DNB hematologist at Sir Gangaram Hospital, New Delhi. Dr. Rupam Deka, he is assistant professor hematopathology at Department of Hematology, Dr. BB Cancer Institute, Guwahati. Dr. Shinto Francis is senior consultant and chief Department of Clinical Hematology and Hemato-oncology at Baby Memorial Hospital, Kozhikode, Kerala. And Dr. Srinath Khirsagar, he is consultant hematologist, hemato-oncologist, and BMT physician at Global Hospital, Parel, Mumbai. He is also attached as honorary consultant hematologist at KG Somaiya Medical College and Research Center, Sion, Mumbai. So next, I welcome all the discussants on board. And we also have our special guest for today morning's lecture. Next. As Dr. Manju Sengar. Next. Madam Manju Sengar is Professor Adult Hematolymphoma Disease Management Group, Medical Oncology at Tata Memorial Hospital, Mumbai. She has completed a training in medical oncology from the prestigious AIIMS, New Delhi. She has done a postgraduate diploma in clinical trials from London School of Hygiene and Tropical Medicine. She is an Accord alumnus. Madam is a recipient of American Society of Hematology Visitor Training Program Fellowship at Duke University, Durham. Her main areas of clinical research are non-Hodgkin's lymphoma, adult ALL, and supportive care. She is also principal investigator for several investigator-initiated studies and has participated in industry-sponsored multi-center clinical trials. Next. I invite Madam and request her to inaugurate today's session and deliver words of wisdom, which will be extremely beneficial for today's participants. Next. Over to you, Manju Madam.
Thank you so much, Dr. Deepanjan. Though I'm really not sure that I am qualified enough to give the words of wisdom, but truly humbled by the opportunity and privilege given by Dr. Agrawal to be here in this forum and speaking to the students. So suggested that I should talk, something which can inspire the graduates, the postgraduates to pursue hemato-oncology as their career in future. So before we say that, why you should join, I'll just give you my reasons why I joined hemato-oncology. I joined medical oncology after completing my MD medicine. I was in truly, deep love with internal medicine, so to say, and not ready to move anywhere except continuing with internal medicine. And that's where my professor and head of the department asked me, what do I want to do as super specialty? And I said, nothing, I just want to continue with medicine. And then he gave me 3 months of my life posted in an area which made me realize that I do need to pursue super specialty. And then I started to think that what it should be, and that's where medical oncology came in my mind, because I felt that that's one place where you can practice medicine day in and day out. And second, that was the most, upcoming field, and a lot of recent advances were happening. CML being the example, imatinib had just come in, some time back. So that fascinated me towards medical oncology. Soon after joining medical oncology and becoming faculty at Tata Memorial Hospital, I realized that I just want to pursue hematological malignancies because that's where my heart lies. So these are my reasons, but for all of you who are still thinking of what is to be done as your subsequent specialty, if you love internal medicine, if you, love to apply that internal medicine day in, day out, nothing other than medical oncology or hematology is your field. The reason being, you will have such a multi-system presentation of these diseases, multi-system affliction by these diseases, as you are going to see in the talk, which Dr. Ashutosh is going to give, is, where you need to apply internal medicine day in and day out. Not only that, you get to treat these patients, they get complications, they get severe infections, and again comes in the multi-system complications and multi-system presentation of these complications. So again, your internal medicine comes handy, and you will, you'll love it. Another reason, if you are into logical thinking and, having a diagnostician's approach, I think this is your area where you need to be there. The diseases come with various presentation, and you need to apply each of this clinical presentation, linking different things, linking investigations, and that's where you need to, if you want to pursue that, you need to be here. If you're the one who loves the thrill of turning somebody very sick, turning back to their home, living their normal life, I think this is the place where you should be. An acute promyelocytic leukemia who comes sick, goes home, comes back with their family, pursuing their future, I think this is where you should be. If you love emergency medicine, if you love critical care medicine, you should be in hematology oncology. More than that, I think this is the place where you love, following recent advances, bringing it to your practice. I think this is a place, I think no other field, and I may be just being partial, but I think there is no other field where translation of biology, bench to bedside, has been so rewarding as hemato-oncology. So I think that's one reason why you should be here. If you want to pursue research, nothing like it. You can, you can pursue research, you can be in the lab, do the clinics, everything put together, and everything together you can continue doing. So I think these are my reasons for doing it. And I guess that all of you who are MBBS students, if there are any in the audience, anybody who's doing their MD medicine or pediatrics, if you want to pursue, this is your field of super specializing. And with that, I thank Dr. Dipanjan, I thank everyone, and look forward to hearing from Dr. Ashutosh. Thank you.
Thank you, madam, for those wonderful words. And I'm sure many in the audience will be inspired to take up hemato-oncology in their future career. With this, I would like to request Dr. Ashutosh sir to please give today's talk on AL amyloidosis. Over to you, sir.
Thank you, Dr. Dipanjan, and thanks to all of you and Dr. Agrawal for your kind invitation today for me to talk about amyloidosis. As Dr. Manju so kindly said, it's probably the epitome of multi-system disease where medicine and hematology interact more so than almost any other part of hematological malignancies. So I'll share my screen. Can you see my screen?
Yeah, it's loading, sir. Just a moment.
Can you see the screen?
Not yet, sir. It's saying that you have shared, but it's not showing.
It's just loading, sir.
Yeah.
Any better now?
Not. Yeah, we can see your slides, sir.
Okay, excellent. So I'm going to talk today about amyloidosis, what happened in the world of amyloidosis, where we have diagnosis, staging, and a little bit about management. It's a disease of protein misfolding, which has been known for over 150 years. But really, it's in the last sort of 15 years, we have made remarkable progress in this disease. This slide just shows you the patients that we've seen in the center in the UK. And until fairly recently, AL amyloidosis was the dominant condition, light chain amyloidosis. Amyloid deposits at one single site, localized amyloidosis, probably accounted for another 15%, and then familial and hereditary amyloidosis, a few percent. But lately, senile systemic amyloidosis or wild-type transthyretin amyloidosis affecting the elderly is increasing in prevalence rapidly. And as you can see with the gray bars on the screen, this is the type of amyloidosis which is being recognized with increasing frequency and now probably accounts for 50% of our work. The reason it is so important for us is that about 23% of all of these patients, maybe a quarter of all patients with wild-type elderly, they may have an underlying monoclonal gammopathy, and therefore the differential diagnosis of amyloid and typing the amyloid fibrils is important. Amyloidosis affects the hearts and the kidneys in 80 to 90% of all patients, affecting liver, the gut, and the autonomic nervous system in maybe another 15 to 20%, and soft tissue involvement in 20% of the cases. So what do you suspect that may have this? This is almost always a clinical suspicion based on the patient's symptoms or a combination of symptoms. The first step to my mind is to do monoclonal protein studies. This is serum protein electrophoresis and immunofixation, as well as urine immunofixation for a monoclonal band and measurement of serum-free light chains. If the monoclonal protein studies are negative, we go down a very different path. AL amyloidosis then becomes extremely unlikely. 98% of patients with AL amyloidosis have monoclonal protein in the serum and the urine. If it's not there, then we're looking at something else. Isolated cardiac amyloidosis, particularly in the older people, is very common, as I said before. And if you just isolated heart amyloid, you want to do a bone scan, a DPT scan, PYP scan, or an HMDP scan. And based on these scans, you can then decide if the patient has AL amyloidosis or a different type of amyloidosis. If it is a non-cardiac amyloid, you definitely need a biopsy, and then you type the amyloid deposits, use the immunohistochemistry, or send it to a reference laboratory. If the monoclonal protein studies are positive, then you definitely need some sort of a tissue biopsy to confirm that it's amyloid by Congo red staining. An abdominal fat biopsy is the easiest, otherwise you biopsy your organ. You then go on to assess the end organ function by echocardiography, CMR is available, proteinuria, type the amyloid fibrils, stage the disease, and then plan the treatment. We've shown this for many years. This is just a series of cardiac MRIs showing from normal to a slight increase in the contrast in patients with very early amyloid to the myocardium becoming completely white, as you can see over here, as opposed to normal black that you can see over here in patients who get more advanced amyloid. And the survival of these patients completely depends on how much amyloid is there. Patients who have got lots of amyloid do really worse. Patients who have little amyloid do better. Very logical. Our challenge really is early diagnosis. It's very difficult to diagnose amyloid early. Can we do something? We have traditional methods. Studied very much is, can we use machine learning for amyloid diagnosis? And this is mainly based on the fact that a lot of patients with amyloidosis present with very common symptomatic themes. And therefore, these in systems where you've got automated analysis are very nicely suited for machine learning. This was one of the studies which did machine learning for patients to look at wild-type cardiac amyloid, looking at speckle tracking on echocardiography, bone tracing, bone scintigraphy, and blood tests. And based on that, they were able to show that with machine learning, they can amyloid with sensitivity and specificity of about 80 to 90%, depending on which cohorts are chosen. And they're also able to base this on a number of other features, and clearly the features which we know very well, such as presence of multiple myeloma, presence of a menopause gammopathy, or presence of carpal tunnel syndrome, then allow the machine learning to the rest of the investigations for amyloidosis. The one study which is probably the most interesting is looking at ECG, and this is a model which is being done by the Mayo Clinic, where they analyze electrocardiogram patients with potential amyloidosis. The electrocardiograms which were done when the patients had come for follow-up at the Mayo Clinic, even before the amyloid was diagnosed. And even in an institution like sorry, is my screen back on? Can you see my screen again?
It's
Yes.
loading, sir.
Yeah, it's
Yeah, we
visible.
can see it now.
It's visible, yeah.
Any better now?
Yeah.
It's visible, sir. The slide is visible, sir.
Okay, great.
ECG by AL in diagnosis of amyloidosis.
Yeah, so basically this is the study done at the Mayo Clinic where they were looking at diagnosing amyloidosis using an artificial intelligence model. And even at the Mayo Clinic where amyloidosis is very well recognized, what they were able to show was that using a machine learning model, they looked at ECGs done before and after the diagnosis of amyloid, and the model was able to predict amyloid diagnosis in 60% of the patients just on a single ECG, mainly even using one lead, V5, but more specifically using bipolar leads, about 6 months before a clinical diagnosis had been made. So we do believe that machine learning is going to be the future for diagnosis of this multi-system disease, even using simple tools like ECG, and we could build this into the ECG machines to allow us to diagnose amyloidosis. survival for patients with amyloidosis has improved over the last decade, but not as dramatically as we may think. This was a study we did in Europe looking at about 5,000 with amyloidosis diagnosed between 2004 to 2010, and then from 2011 to 2018. There's clearly been a survival improvement, but as you can see that the overall survival curves are not dramatically different. And the early mortality of patients with advanced cardiac amyloid, the so-called stage 3 disease, remains essentially unchanged compared to how it was 10 years ago. When patients are diagnosed, staging system using BNP and troponin, now this has been done for years, over 20 years, still remains our gold standard. Patients who have got NT-proBNP over 8,500, the so-called stage 3B patients, have very poor outcomes. And there are very few things which have been able to better the staging system for amyloidosis. The one thing we are able to show, which now we know can improve on the staging system, is using global longitudinal strain on 2D echocardiograms, and the GLS pattern can allow us to differentiate between different stages of amyloidosis. And patients with very poor strain do have very poor outcomes compared to patients with better strain. And therefore, this is a functional marker in addition to biomarkers, particularly useful when patients, for example, have poor renal function. And amyloid is just not protein deposits. You've got direct proteotoxicity, you've got vascular deposits of amyloid, and then you've got interstitial deposits. We can show that the amyloid light chains are cardiotoxic by cardiac MRI scan, which show significant myocardial edema when we use T2-weighted sequencing. And this myocardial edema predicts for poorer outcomes. The red curve is patients with myocardial edema. The blue curve is patients who have got less edema. And then when we look at these patients serially, what you can see that in treated patients with AL amyloidosis, the proteotoxicity disappears and the myocardial edema reduces. There are a number of newer agents which are coming on for amyloid diagnosis. This is one such agent. This is something called as florbetaben. It is licensed for imaging the brain in Alzheimer's disease, and it can image the heart in AL and ATTR amyloid, and may even help us to differentiate between these two amyloidosis. We're just about to start a phase 3 clinical trial to confirm these early findings. There are other agents, which is labeled P5+15, which is a small peptide, and this can image amyloid in internal organs, such as the liver and heart. And we hope this PET scan-based tracer may become a licensed diagnostic agent for amyloid imaging if the trials confirm these findings. We are making efforts to try and grade our response to treatment using biomarkers, and we've just recently had this paper accepted in the Journal of Clinical Oncology, done together with colleagues at the Mayo Clinic, showed great response of how significant the reduction in the cardiac biomarkers is following therapy. And patients who essentially normalize their cardiac biomarkers have much better outcomes than patients whose cardiac biomarkers remain persistently high. Cardiac MRI scans are also very helpful, and they can tell us a bit about amyloid in other organs in addition to that. We can map the amount of extracellular contrast using specific equations which are now publicly available. And using this contrast tracer, you can see that there is amyloid in the internal organs. This is a series of patients that which show improvement in MRI and worsening in MRI, and compared with serum amyloid P scintigraphy, which we've been using regularly in the UK for amyloid imaging. This is not a modality which is easily adaptable outside of our center because of the complexity of how the tracer is made. But MRI scans can easily be used almost in any country. And these MRI scans, when they're done for the heart, you automatically Sorry, I have to apologize for my poor internet connectivity today. I'm actually in Nagpur, and therefore this is probably not what I would normally expect. But anyway, here we are. I hope my screen is back on again.
Yes, sir. Yes.
So all patients with amyloidosis have an underlying bone marrow clone. And patients who tend to go more towards the myeloma end of the spectrum have much poorer outcomes than patients who are more in the MGUS end of the spectrum. So patients with less than 5% plasma cells, much better than more than 3% plasma cells. And cytogenetic abnormalities, particularly T1114 translocation, which is seen in about 50% of the AL patients, also portends a slightly poor prognosis, possibly because these patients may not respond so well to our standard therapies with bortezomib. Light chains, plasma cells in amyloidosis have described very different profiles of transcriptomial than we see in myeloma and MGUS. This was a recent study from our Spanish colleagues. We showed that proteins which are linked to glycosylation are much higher in patients with amyloidosis compared to myeloma, as proteins linked to oxidative phosphorylation, MYC or ribosome biogenesis are much higher in myeloma and MGUS. This is to be expected as amyloid is a protein misfolding disorder, whereas in multiple myeloma, we see the cellular multiplication as the primary problem. We can see this when we look at the light chains in the blood by mass spectrometry. Normally, we should see a nice little peak of the light chains, as you can see on the right-hand panel. But in AL amyloidosis, you can see these multiple peaks of glycosylated light chains using mass spectrometry. These are light chains which are very typical, particularly for kappa in AL amyloidosis. The Mayo group did a study looking at light chain glycosylation in various disorders. And in patients with multiple myeloma, probably about 10% of patients will have glycosylated light chains, particularly when the type is kappa. But in AL amyloidosis, about 30% will have glycosylated light chains. The disease where light chains are glycosylated most is, of course, cold hemagglutinin disease. Light chain glycosylation can predict for development of amyloid. Patients who had glycosylated light chains in the Mayo Clinic group had a significantly higher risk of developing amyloid, and maybe these are patients who should be closely for development of amyloidosis. More recently, from colleagues in Italy, were able to show that this light chain glycosylation is linked to a very specific mutation, as you can see here, in a peculiar sequence on the E strand, mainly of the NFT sequence. And we now know that this light chain glycosylation in amyloid, particularly in patients with kappa light chain disease, is linked to a specific mutation, and we may be able to track this and understand this better as time goes on. Our treatment choices in amyloidosis are growing as newer drugs are becoming available for plasma disorders. And as you see in this figure here, the overall mortality over 2 or 3 years is gradually decreasing. 10 years ago, this was maybe 60%. Now we're down to 20 or 30%. The deep responses, which are associated with improved outcomes, has also improved in patients. Patients who achieve a complete response to treatment, irrespective of their disease stage, have significantly better outcomes than patients who don't achieve a deep response to chemotherapy. And therefore, it's really important that we aim for achieving a deep, complete response as early as possible in amyloidosis. Published an algorithm for response assessment in amyloidosis. Sorry, my slides too much. So we published an algorithm for response assessment of amyloidosis, and what we can show is that patients who respond at 1 month have significantly better outcomes compared to patients who respond later. And we certainly believe that we should change treatment as early as 1 month in some patients with amyloidosis who don't respond to treatment early. Our belief is that patients who have high light chains of presentation, difference between the involved and the uninvolved light chains are more than 400, who don't achieve at least a 50% reduction by the end of cycle 1. There's very few of these patients will get a deep response. Patients, of course, who get a 90% or greater reduction can carry on treatment. And then patients with intermediate risk, we would probably carry on for a couple of months cycles before therapy. There are different definitions of response assessment. risk disease assessment, which is important now in multiple myeloma and number of other disorders, is also crucial in amyloidosis. Patients who are MRD negative on bone marrow, either by next generation flow cytometry or by next generation sequencing, have significantly better outcomes and much better organ response than the patients who are MRD positive. Amyloid, we also use the blood for MRD monitoring using mass spectrometry for light chains. And this is a technique which is likely to become commercially available in the next few months. And patients who are mass spectrometry negative will have better outcomes than patients who are mass spectrometry positive. And you can see that all the kappa and lambda values are essentially normal follow-up after treatment. Lambda light chains of 9.4, you can see that there is a tiny peak that you can see on mass spectrometry for this patient, suggesting that this patient was MRD positive. Treatment for amyloidosis, our baseline algorithm hasn't really changed for many years. We have now guidelines published by the International Society of Amyloidosis, both for stem cell transplantation and non-transplant chemotherapy. Patients with low-risk disease, those who have good organ, not significant cardiac involvement, good renal function, are candidates potentially for consideration of stem cell transplant. We would generally consider induction therapy with bortezomib, followed by a transplant, or some patients could go directly to a transplant, and patients otherwise are treated with combination chemotherapy. Certainly, when we did a matched comparative analysis of low-risk patients with bortezomib treatment and cell transplantation, if patients achieve a deep response, there wasn't a substantial difference in outcomes of these patients. And therefore, our belief is that if your patients achieve a complete response with stem cell transplant, they have low plasma cell burden, less than 20%, then you may consider carrying on with treatment, but the benefit of transplant in this cohort remains to be proven beyond. This was a study presented at ASH last year showing refractory patients undergoing stem cell transplant for amyloid. The deep responses for refractory patients are less than 30% and don't believe there is a role for transplantation in this patient setting. The Andromeda clinical trial really was one of the pivotal phase 3 trials which assessed daratumumab CyBorD with VCD in patients with amyloidosis. And many of you may have seen these slides before from either my presentation or other presentations, that the primary endpoint of this trial was achieving a complete hematologic response rate, and 53% of patients with primary with AL amyloidosis achieved the primary outcome in the DARA VCD arm, compared to 18% in the VCD arm in the primary analysis at 11 months. But when a longer follow-up was done at 24 months, 60% of the DVCD patients were in a CR compared to just 20% of patients with VCD. It's important to remember that the DVCD patients in this trial carried on getting daratumumab to complete a total of 2 years of treatment, whereas the VCD patients received a total of 6 cycles of therapy. And this benefit was across all subgroups, including patients with cardiac disease, as well as those with T1114 translocation, who don't apparently do so well with bortezomib-based treatment. A lot of these patients then went on to get organ responses. At 6 months and 18 months, you can see that at 18 months, nearly half the patients had achieved a cardiac response and a renal response. And this in amyloidosis is certainly unprecedented. Importantly, apart from infections, we didn't really see any serious adverse events in the DVCD arm compared to the VCD. And of course, daratumumab has been reported in a number of different studies in the relapsed refractory setting. And as you can see here, the response rates are in the order of 80 or 90%, with deep responses in the order of 32%, depending on what pre-treatments these patients had. If daratumumab as a single agent or daratumumab in combination with other drugs may have a role in patients with relapsed refractory disease. We did a small study looking at carfilzomib in patients with amyloidosis. Using a once-weekly protocol, we were able to show that carfilzomib is effective and safe in this group. And we use a dose of 27 milligram per meter squared or move up to 45 milligram per meter squared. This is particularly important in patients who have significant autonomic venetoclax targets patients with T1114 translocation with overexpression of BCL2, and 50% of AL patients will have this translocation, and therefore venetoclax becomes an amyloid treatment. We reported this study now about 2 years ago at venetoclax, along with dex of venetoclax, along with bortezomib and dex in amyloidosis, showing that in relapsed refractory disease, the response rates are very high, about 80% of patients achieving a CR or a VGPR. Where it is available, we do believe that venetoclax, along with dexamethasone or venetoclax bortezomib dexamethasone, is an important treatment option for amyloidosis patients. Belantamab mafodotin is a BCMA-targeted monoclonal conjugated with a toxin. This was, the graph shows one of our multiply refractory patients treated with 6 prior lines of therapy, achieving a complete response to treatment with 3 cycles. We have recently had a paper accepted in the Blood Cancer Journal looking at about 12 patients we treated in the UK, showing that CR VGPR rates using this single agent are in the order of about 60%. And an American study recently reported the same. We have a phase 2 clinical trial that's running in the UK and Europe. But again, this is a really helpful agent in patients who are relapsing after daratumumab or IMiD-based regimens. Of course, immunotherapy is very exciting, and we think we will have a role for this in amyloidosis. This was the first of a CAR T-cell treatment for patients with renal amyloid, showing deep response and improvement in proteinuria. But this remains to be proven, amyloid much fragile, and this phase. Clearly, we need to remove amyloid fibrils, and therefore our goal really is how do we have agents that will allow the body to clear the amyloid deposits rapidly. Progress in this area has been slow. We've had a couple of negative clinical trials. This was a paper published 2 years ago using KL1, which is an antibody targeting amyloid fibrils. In this study, 8 of the 12 patients treated achieved a cardiac response after a single dose of the monoclonal antibody, and a third of the renal patients also achieved a response. This has now gone on to 2 very large phase 3 clinical trials for patients with cardiac amyloidosis, 3A and 3B, and it remains to be seen how these trials come up. Using the same antibody, they were able to show that the global longitudinal strain improves. This then went on to a small phase 2 study, which is show that there was some improvement in the global longitudinal strain, as well as improvement in proteinuria in patients treated with a combination of DARA VCD plus KL101. Neo-001D, or belantamab, is another monoclonal antibody that was initially in phase 3 clinical trials and was able to show that patients with advanced stage cardiac amyloid seem to have an improvement in survival. This is also now undergoing phase 3 trial. The initial phase 3 trial was negative, but in a subgroup, it may be much more beneficial. Let's see how this pans out. We have a number of different trials that we are recruiting in amyloid. We have, of course, got 2 trials with the monoclonal antifibril antibodies that are targeting amyloidosis and cardiac amyloid. We have got a trial which is looking at single-agent daratumumab followed by VCD, because we believe the toxicity from VCD is really what contributes to the challenges in amyloid patients. We've got a couple of imaging studies with the 2 agents that I showed earlier on. We've got a study with a BCMA-targeted bispecific antibody, teclistamab, which is now licensed for treatment of relapsed refractory myeloma in the US and Europe. And we should hopefully study this in patients with amyloidosis who don't achieve a good response to therapy. We've got a relapsed refractory study with belantamab, and then we are studying sorry, just to conclude, AL amyloidosis remains uncommon, but it is not as rare as we thought it was. So please think about amyloid in a patient with unexplained multisystem disease, particularly in context of pulmonary gammopathy. You will get patients from cardiologists with cardiac amyloidosis. Automatically don't assume that they are AL or ATTR. They do need proper diagnostic workup. 2D strain on echocardiogram, MRI are very helpful for disease assessment. Graded organ response assessment is very useful. Antiplasma cell therapy have, of course, changed. Daratumumab with VC, if available, is the treatment of first choice. I do believe that where daratumumab is an expensive agent, VCD still remains the treatment of choice, and stem cell transplantation has a role in this group of patients. Lenalidomide, pomalidomide are helpful in relapse disease. Venetoclax is very attractive in patients with T1114 translocation, and if accessible, should certainly be considered in patients with relapse disease with this particular antifibril strategies are in clinical trials. They are tantalizing, but are not yet proven. And of course, the problem of early diagnosis remains, and therefore I have ended with the same statement I made before. Please do think about amyloid in a patient where you've got multi-system problems, cardiac and renal, nerves and heart. Amyloid always remains as a differential diagnosis. Thank you.
Thank you, sir, for the wonderful talk. I'd like to welcome all the discussants once again. And I'm sure there will be many questions to ask, and sir will oblige us with his answers. To begin the discussion, so maybe the discussants can raise their hand, and yeah, so I can see Dr. Jag. So, and then we can, so maybe start with Professor Dr. A.K. Tripathi.
Yeah, should I say something? Yeah.
Yes, sir, please.
Hello. First, I must congratulate Dr. Ashutosh for very lucid but comprehensive presentation. Particularly, it was very exciting to see the role of artificial intelligence, machine learning in early diagnosis and few biomarkers. I have a small question. Is there any role of giving doxycycline in patient of amyloidosis? Is it still considered to some extent, or there's no role?
So we reported improved outcome using doxycycline, but there was a recent phase 3 clinical trial from a Chinese group which did not show any benefit of doxycycline. We think it remains something that we still use quite routinely because we do think it reduces infections and it may have a benefit. But I think the role is questionable now that the phase 3 trial has actually shown no significant survival advantage. The inclusion criteria were quite different. So I think doxycycline, if tolerated, yes, but if not tolerated, I would not push it.
And what is the dose?
So we normally use 100 milligram once daily, if tolerated, twice daily.
Okay. Thank you.
Yes, yes, Dr. Rasool.
So you're muted.
Okay, sir, can you listen me now? So Dr.
Yeah.
Javed from Srinagar.
Yes, sir. Yes, sir, audible.
Thank you, sir, so much for a wonderful talk. I have just two queries. One is that why directive fibril targeting agents are not that useful as the literature says. But theoretically, it seems that they should be the wonderful drugs. I don't know the reason. Maybe you can say something on that, your good self. And second is, how should we diagnose it in the presymptomatic, presymptomatic time? And is there any role of screening in the general population for AL amyloid?
So I'll answer the third one first.
Okay, sir.
So there is no role for screening the general population for amyloidosis because it is really a very rare disease. There may be a role for screening very older patients for wild-type senile transthyretin amyloid, for which there are a number of treatments, not AL amyloid, because that is probably much more common. So that's number one. The second one was antifibril strategies. Why are they not very useful? I think the problem has been developing specific antibodies which can target amyloid fibrils. As you know, that in every single patient with AL amyloidosis, the fibril sequence is different because the immunoglobulin gene rearrangements are different. And therefore, getting a single antibody that will target every single patient with AL has become a big challenge.
Right,
and
sir.
therefore, what we've been working on is targeting not necessarily the fibril, but some of the structures around the fibril, which are common across all different amyloid types. So I just think it's a matter of time, because in animal models, we can demonstrate that using
Okay, so the third one
antifibril
was
antibody, we can remove amyloid very quickly. And then your third one was screening the pre-symptomatic patients with for amyloidosis. And these are, sorry?
Pre-symptomatic, during the pre-symptomatic
Yes.
period, how should we diagnose this?
So I think that is a really
After
important
relapse.
area. And these are your patients with multiple myeloma, Waldenstrom's macroglobulinemia, or monoclonal gammopathies that you're following in your clinics. And two simple tests: urine dipstick for albumin and measurement of NT-proBNP maybe once or twice a year. I think those are your two tests. 90% of amyloid patients will have heart involvement and they will have kidney involvement. So if either of these two tests start becoming abnormal, then you need to think, is something going on? Albuminuria is particularly important, as not only amyloid, but MGRS, monoclonal gammopathy of renal significance, is also not that uncommon, and I don't think we recognize it often enough. So these are simple tests you can do in the clinic that will allow you to diagnose amyloid. And then, of course, if you get unexplained symptoms like weight loss, loss of appetite, diarrhea in monoclonal gammopathy patients, which are persistent and carry on progressing, think about amyloid.
Thank you, sir.
Thank you, sir.
I've taken two questions from the discussions. Now I'll be taking two questions from the audience. So Dr. Thomas Kuncheria wants to know, what is the role of NT-proBNP and troponin T in a suspected amyloidosis patient already having renal failure? Sir, can you please take this up? Role of NT-proBNP and troponin T in a suspected amyloidosis patient already having renal failure.
So in simple terms, none, because both of those markers go very high in renal failure. You can use BNP in renal failure, which is slightly more useful. But we find that both troponin T and NT-proBNP are not really helpful for amyloid patients in renal failure. We don't track them, we don't monitor them. And that's where the role of the strain in echocardiogram becomes really important for assessment and monitoring. If the NT-proBNP is very high, for example, it is 50,000, 60,000, something like that, then you know that there is something going on with the heart. And at that sort of number, you can track it. But NT-proBNP under 10,000 probably doesn't tell you very much for a patient with renal failure.
Right, sir. So Dr. Thomas also wants to know, what is the cutoff of NT-proBNP in diagnosing cardiac amyloid and its prognosticating? Is it 332 or 1800 according to Mayo staging, or 8500 picograms per ml? So the cutoff of NT-proBNP, sir.
So the cutoff is 332. Any patient over 332 by definition becomes is suggestive of cardiac amyloid. 1800 is used in the new Mayo staging for diagnosing stage 1, stage 2, and stage 3 cardiac amyloid. So that's one of the thresholds used for staging. And then the other threshold used for staging for particularly very, very poor prognosis patients is 8500. So all three cutoffs are important. 332 for diagnosing amyloid, 1800 for using in the new Mayo staging system, which incorporates free light chains. And then 8500 is a cutoff which defines your very poor prognostic patient criteria, irrespective of whatever staging system you want to use for amyloid.
Thank you, sir. I think Dr. Ramesh, you wanted to ask some questions.
Yes, sir.
Dr.
Sir, good
Ramesh,
morning. Yes, sir. Good morning. So I have two queries, sir. My first query is the extension of Dr. Javed's question. So in cases of MGUS, like how frequently should we monitor for, should we screen for amyloidosis? It's my first question, sir.
So how frequently should you screen for amyloidosis? I think I would probably screen no more frequently than once a year because it's quite rare in MGUS patients and it is often quite invasive doing frequent screening. But once a year, particularly in patients who have a lambda light chain, I would screen them more than patients who've got a kappa light chain because kappa amyloid is much less common than lambda. So if you had an MGUS with lambda light chain excess, they are the ones who would be important for targeted screening.
Okay, sir. Thank you, sir. My second question is like, what is the maximum tolerated dose of carfilzomib in patients who are either intolerant to bortezomib or who are having a stable or progressive disease with bortezomib?
So we use carfilzomib given once weekly. We don't use it given twice weekly. So we use it day 1, 8, and 15 rather than day 1, day 2, day 8 and 9, because the twice weekly protocol resulted in a number of cardiac deaths. So you should not give carfilzomib twice weekly in an amyloid patient. That's the first thing. Once weekly carfilzomib, we normally start at 27 milligram, 20 milligram dose 1, 27 milligram from day 8 onwards as per normal. And then if patient is tolerating it, will increase it to the maximum of 45 milligrams per meter squared. We have not used it. We have used 56 milligram per meter squared in an occasional patient, but you have to remember it is cardiotoxic, and if the patient is cardiac amyloid, there is a high risk of cardiac toxicity. So we do an echocardiogram for carfilzomib patients every month to make sure that they are not dropping the ejection fraction.
Okay, thank you, sir.
Thank you. I'll move on to the next question from the audience. So Dr. Naresh Tayade wants to know, what is the minimum age of presentation of amyloidosis?
Minimum age, the youngest patient I've seen with AL amyloidosis is a 21-year-old. So it is uncommon, but the commonest age is between 60 and 80, as you see with MGUS and myeloma. You do see familial amyloidosis at earlier age. You see secondary amyloidosis at earlier age, but not primary AL amyloidosis. Is pretty uncommon under the age of 30 and certainly rare under the age of 40.
Thank you, sir. I think Dr. Chitra Madiwale wants to ask the next question. Dr. Chitra.
Thank you, Dr. Vichalikar, for a wonderful talk. Being a pathologist, I wanted to know what is the best method for subtyping of amyloid, particularly with reference to kidney biopsies?
So from my perspective, the gold standard remains mass spectrometry for light chains if you can access it. If you're doing immunohistochemistry, then using a panel of monoclonals is really important rather than using a single antibody. With the commercial, for example, the commercial DACO antibody to AA amyloid, secondary amyloidosis, there is about a 20% false positive rate. For patients, for standard antibodies to kappa and lambda light chains, we can't really differentiate because of background staining in about 30% of the patients. And then we use the commercial antibodies for kappa and lambda diluted. I think for kappa, we use a 1 in 40,000 dilution, and for lambda, we use a 1 in 60,000 dilution of the commercial antibody. If you use the antibody undiluted, as you might do for, say, light chain staining in myeloma, you'll just get background, and then the diagnosis becomes very challenging. So we use a panel. We've got some homemade antibodies that we've got for kappa and lambda light chains. We use 2 different commercials. So we do about a set of about 16 to 20 different antibodies in every single case when we're using immunohistochemistry. But you need to cross-check with a different antibody. That's the main thing. If you find it's lambda, or if it's a use an antibody from a different manufacturer to cross-check that you're still getting the positivity.
Thank you. Thank you.
Thank you, sir. So now we move on to another next question from the audience. So again, related to subtyping of amyloidosis. So in Dr. Krishnaratnam Kannan wants to know, in case of AL amyloidosis, if the IHC is showing light chain restriction, should we still do spectrometry?
The answer to this question is, if you're confident that your IHC laboratory is able to type it accurately, you don't need to do mass spectrometry. But you really need to have a good lab which is routinely doing IHC for amyloidosis. And certainly one of the things which I would be very interested in helping, if anyone is interested in this audience, is to set up a reference laboratory or a few reference labs in India to be able to type amyloid, because it's really difficult for all lab chemistry routinely for amyloidosis, as it's pretty uncommon, and you need quite an extensive antibody panel to be confident that your IHC is accurate.
Thank you, sir. Over to Professor Rajiv De for the next question.
Yeah, thank you for an excellent talk. So I have 2 transplant-related questions. One is, we know that in amyloidosis, autologous transplant is difficult because of the organ damage. So whether novel combinations that they are transplant. Hello. Well, whether the novel agents are making transplant redundant or delaying transplant, or the novel agent, by improving organ function, they facilitate autologous transplant. So what is the relationship between novel agents and autologous transplant nowadays? This is my
Well,
first.
I think that's probably the most important question that we are having a dilemma in amyloidosis, because to patients treated with novel agents like daratumumab, their organ function improves and more patients become eligible and fulfill the eligibility criteria for transplant. On the other hand, patients, when they get a complete response, can remain in remission for 4 or 5 years and may not require further treatment. So there may not be a role to expose them to a transplant. And our practice certainly is that patients who get a complete response with a DARA-based regimen, we harvest them but don't transplant them. And we now transplant patients in their first relapse. So after they've relapsed, we'll reinduce them, get them into a CR and transplant them. So our practice has now changed from transplanting patients in first remission to transplanting patients in second remission.
Okay, thank you, sir. And one more question is the role of solid organ transplant in amyloidosis. So what is the reality or the solid organ?
So solid organ transplantation, heart transplant is certainly a life-saving procedure for a very small number of advanced young AL patients who don't have extra cardiac involvement. But then often the biggest problem is the availability of organs, and the patients often die before they can get a heart. Renal transplantation for patients with AL who are in a complete response, the outcomes are very, very good. Very few kidneys are really lost to recurrent amyloid. So in patients who are suitable for a kidney transplant, who achieve a complete response to therapy, renal amyloid patients, we would certainly recommend consideration for a kidney transplant. And we would generally have those patients undergo an autologous transplant either before or after the kidney transplant.
Thank you, sir.
Thank you. The next question is from Dr. Afaq Ahmad Khan, who wants to know how long will you continue induction in AL amyloidosis? What about consolidation and maintenance?
So if given VCD standard treatment, we only give 6 cycles. Rarely we go up to 8 cycles. We don't give many maintenance or anything else in AL patients. They don't tolerate it. The only time we have now started giving maintenance is based on the Andromeda trial. When patients are on DARA VCD, we give DARA VCD combination for 6 months, and then we continue the DARA according to the trial protocol for between 18 to 24 months. Patients don't tolerate lenalidomide or pomalidomide and amyloid too well, so we never give those as maintenance. And certainly there's no data on maintenance after stem cell transplantation in amyloid, but there is data on consolidation for patients who have had a melphalan auto who don't get a CR. You can give them a treatment with either bortezomib or carfilzomib, and a very high portion of those patients will go into a CR afterwards.
Thank you, sir. Dr. Mona, you can ask the next question.
Excellent presentation, sir. So I have 2 questions. The first question is a clinical scenario. There is a 56-year-old female, the kidney being the organ involved, and after 6 cycles of VCD, so she had a DFLC of 16 milligrams per liter. Just 1 month after stopping the VCD, she had the DFLC again rose to 50 milligrams per liter, sir. And there was no organ response till then. So how should we proceed in this scenario, sir?
So she is somebody who's relapsing rapidly, and she requires reinduction treatment. If she's fit enough for an autologous transplant, then there would be a role for an autologous transplant in this patient. The option might be to go straight to a transplant, or to give her some more VCD, maybe another 2 cycles because she had such a good response, and transplant her as soon as she has had a good response to maybe another 2 cycles of VCD. If you have got access to DARA, then I would actually give her DARA VCD, get her into a CR, even with 2 or 3 cycles, and then transplant her after that.
Okay, sir. Okay, thank you, sir. My second question is, sir, when in the clinical setting, sir, how many is it advised to get cardiac MRI in all the patients who have a cardiac involvement, sir, for a better understanding of the disease?
It's a very useful tool for understanding what's happening with cardiac amyloid, but it's not required. If your echocardiogram is very clear-cut, MRI really offers you no other advantage there. But where the echocardiogram is not giving you the answer, that's where the MRI really becomes important. MRI is important in assessing response to the heart. So example, if you are really doing it very rigorously every 6 months, then you can use it for tracking, but it has to be done in the same center with the same protocol, and it's not that straightforward. So I would use it as a diagnostic tool where echo is not very clear-cut.
Okay, thank you, sir.
Okay.
Thank you, sir. The next question is from Dr. Malini. I think you have covered this partially already. So if a patient has achieved CR with CyBody alone, does ASCT still have a role in such patients?
So the only time we would do ASCT in such patients is if they're presenting with more than 20% plasma cells at presentation. But if they are in the CR and less than 20% plasma cells at presentation, we would not do an ASCT as long as you had a proper CR with low light chains. But there would be a role for ASCT if the patient relapsed.
Thank you. Dr. Rupam Dekha, your turn.
Good morning, sir. I wanted to know good morning, sir. So I wanted to know, in a case of proven presentation like a cardiac amyloidosis and when the abdominal fat biopsy is showing positivity for amyloid, what is the role of doing a bone marrow examination in those cases?
So the bone marrow examination will tell you the percentage of plasma cells, which has got quite a prognostic significance. If you're able to do genetics on it to look for T1114, it might allow you targeted therapy. And then, as I was saying, patients who present with more than 20% plasma cells may be candidates for an autologous transplant, more than patients who present with low-level plasmacytosis. So it gives you a lot of prognostic background information about the underlying clone, which allows you to sort of fine-tune your treatment better.
Thank you, sir.
And of course, you have to remember that a small number of patients will have a lymphoplasmacytic lymphoma or Waldenstrom's underlying, and the treatment then will be very different.
Yeah, that was actually what I was wanting to ask you. Thank you, sir.
Thank you. So the last question from the audience so far is from Dr. Krishna Ratnam Kannan again, who wants to ask if can ATTR amyloid present as renal involvement as well, or is it mainly cardiac?
So senile ATTR amyloid or even familial ATTR amyloid almost never involves the kidney. So it's either a cardiac disease, and the hereditary ATTRs are either cardiac and neuropathic diseases. So renal involvement primarily in ATTR is extremely rare.
Thank you, sir. I have a question, sir, if I can ask. So I have a patient with Waldenstrom's macroglobulinemia with cardiac amyloidosis. So generally, how do you treat such patients? You give bendamustine rituximab, or you give bortezomib-based therapy?
So we either give rituximab VCD or rituximab bendamustine.
Okay.
Both are really good regimens.
So I treated this patient with 6 cycles of rituximab bendamustine. He has responded biochemically, so the protein electrophoresis and the free light chain ratio is now normal. However, the cardiac function has not improved significantly even after the end of 6 cycles. So in this situation, sir, what would your next approach be?
So if your patient has achieved a complete response, then the cardiac function can take up to 2 years to improve. So I would really just give him rituximab maintenance every 2 months and just sit tight and watch. It will take time, but it will improve if the patient is in a true CR.
Thank you, sir. Dr. Rajiv, would you like to ask any other question? I can steal your hand raised. Okay, so I think if there are no further questions, maybe we can end today's session. I would like to propose a vote of thanks by thanking Mr. Keyur Soni and team MCure. I'd also like to thank Mr. Yash, Mr. Kalpesh, and the team Perfect Square. I'd like to thank the executive committee of Mumbai Hematology Group, especially Professor M.B. Agarwal sir, for organizing today's webinar. Our chief guest, Dr. Manju Sengar madam, and obviously our guest speaker, Dr. Ashutosh Vechalekar, for sparing his Sunday morning and enlightening us on this very interesting and difficult topic. And all our discussants who are themselves eminent hematologists for taking out time from their busy schedule and participating actively in today's webinar. Over to you, Kalpesh. Thank you all once again.
Thank you.
Thank you, everyone.